Welcome everyone to this video. Today I'll be guiding you through an ArtiSential-assisted left adrenalectomy. I hope you find the content informative and enjoyable. Feel free to share your thoughts in the comments below. And don't forget to subscribe to my channel to stay updated on future procedures. This case involves an 82-year-old female patient who presented with an incidentaloma of the left adrenal gland. While the dexamethasone suppression test was positive, the tumor was otherwise endocrinologically inactive. We proceeded with an ArtiSential-assisted transperitoneal adrenalectomy in accordance with the MDT recommendation. The procedure was completed without intraoperative complications and the patient's postoperative course was uneventful. The CT finding is demonstrated in this short sequence. The following illustrations provide a detailed depiction of the intraoperative setup and port placement. The procedure is started by removing some peritoneal adhesions in the upper left quadrant. This step is performed to prepare for the mobilization of the splenic flexure, which is necessary to visualize the anterior renal fascia and the lower border of the pancreas. Once these structures are exposed, the pancreatic body can be lifted, revealing the space that houses the left adrenal gland. The peritoneal margin between the lateral border of the colon and the anterior renal fascia can now be clearly visualized, and dissection along the avascular space is performed to take down the splenic flexure. The surgical assistant standing on the right side of the patient is providing the necessary countertraction in order to perform a bloodless monopolar dissection with the ArtiSential scissors. The lower border of the pancreas is now clearly visualized. Dissection continues posterior to the pancreas, with particular attention given to protecting the pancreatic surface throughout this step. The assistant is instructed to gently lift the pancreas using a non-traumatic instrument. This maneuver enhances visualization of the space containing the adrenal gland and enables the surgeon to perform precise dissection of the small blood vessels. The next step can certainly be performed using a vessel sealing device such as ligature or a harmonic scalpel. However, if these instruments fail to achieve adequate vessel closure, managing the resulting bleeding can be challenging, as locating small veins or arteries may become cumbersome. When working with articulated instruments like ArtiSential or a robotic system, I recommend opting for meticulous monopolar dissection. This approach allows you to isolate and clip the vessels individually, ensuring greater precision and control. The surface of the kidney is now visible, and dissection continues along the avascular plane until the first small veins and arteries are encountered, mainly on the medial aspect. The first vein collateral in the perirenal fatty tissue is clipped and divided. Further mobilization of the left colon is here needed to allow for more visibility. The left suprarenal vein is now visualized, clipped, and divided. Further suprarenal arteries are encountered, clipped, and divided on the medial and cranial aspect of the adrenal gland. The last attachments are dissected until the entire gland is detached. The specimen is retrieved through the camera port. Thanks for watching, and until next time.